Good morning, good afternoon, and good evening, everyone. My name is Abdullah Biad. I'm Director of Macroeconomic Research at the Asian Development Bank. And on behalf of the ADB and the Center for Global Development, it's my pleasure to welcome you all to this ADB CGD virtual event on mobilizing health taxes for development in Asia. So this event is part of the ADB's effort to work with various policy and research partners, including the CGD, to advance knowledge on development issues in Asia. Our research team at the ADB produces the twice-yearly Asian Development Outlook, and the report that was released just last month focused on mobilizing taxes to support development. Let me briefly highlight three key takeaways from that report, as it helps provide context for today's event. First, developing Asia faces growing demands for public spending on healthcare, education, environmental protection, plus, of course, recovery from the COVID-19 pandemic. But tax revenues in the region are low, at just 16% of GDP, even prior to the pandemic. That's 3 percentage points below Latin America and 10 percentage points below OECD levels. Second, and perhaps fortunately, our study finds that tax revenues in the region can be strengthened by improving the collection of existing taxes, as well as tapping into new areas. We estimate that on average, reforms could boost tax revenues in the region by about 3 to 4% of GDP. Third, our report looks at specific ways in which this can be accomplished. While the specific reform pathways will be different for each economy, all governments in the region can collect value-added tax more efficiently, and they can rationalize tax incentives. More revenue can be tapped from personal income and property taxes, which would also, of course, improve equity. Governments can bring more firms out of the shadow economy by lowering business registration costs, for example, and it can also collect taxes on the fast-growing digital economy. Finally, governments can raise taxes on harmful products like alcohol, tobacco, and carbon emissions, and this would generate revenue and directly improve health and the environment. The mobilization of health taxes, which is our topic today, can play a key role in supporting development in Asia. To do that, though, we need to understand the potential for these taxes to help lessen the health and economic costs associated with non-communicable diseases. We also need to assess their implications for tax revenues. Just as important, though, we need to understand the practicalities of implementing such taxes. What are the political and other challenges that policymakers face? Do such taxes have distributional consequences? And should revenues from these taxes be earmarked for the health sector? These are just a few of the issues that I hope today's event can shed light on. Our main presenter today is Chris Lane, who is non-resident fellow at the CGD. Prior to that, he had a long career at the IMF and had also worked with various organizations, including the WHO, the World Bank, and DFID on health issues. So he's really a specialist. He has a lot of knowledge on this area. His presentation will be followed by a panel discussion featuring several distinguished experts, and it'll be moderated by my colleague, Grace Tian. So with that, let me thank the organizers from both the ADB and CGD and turn the floor over to Chris. Chris, floor is yours.
Thank you very much, Abdul. Good morning, good evening, everyone, wherever you are in the world. In fact, we seem to be all over the world on both the Western Hemisphere, Eastern Hemisphere, North and South. I wonder if we can put the presentation up. That would be very helpful. So yeah, I'm going to give just an outline of the paper, the background paper that I wrote for the Asian Development Outlook. And let me give you a very quick run over, next slide please, of what I will talk about. So first I will ask the question, why health taxes at this particular juncture, and then look at some of the advantages and disadvantages that you face in implementation of health taxes And then I'll try and give like an outline of where developing Asia is currently in terms of tobacco taxes, alcohol taxes, and taxes on sugar-sweetened beverages, or SSB taxes, which have become, I guess, a test case for using taxes to improve diets. And then I'll try and conclude with a few policy priorities that, as a lead into the panel discussion. Next slide, please. So, I mean, there are two fundamental rationales, economic rationales for corrective health taxes. One is a century old. It was really originated by Pigou in 1920, that taxes can be used to raise prices of goods to reflect their social costs of consumption. So in this case, if you consume a good and you adversely affect somebody else, for example, through secondhand smoke or accidents, crime or violence, then it's welfare improving to raise taxes to reflect that cost that is being borne by others. But the second and more recent sort of rationale for health taxes is to correct for what are known as internalities. It's a bit of a jargon word, but it's basically self-imposed costs on human health. And I think this has been, and for example, we know that about 10 million deaths a year are in developing Asia are attributable to alcohol, tobacco, and unhealthy diets. So these are not trivial. These are not trivial costs, and in many respects, the internalities are larger than the externalities for these products. And there's a rich behavioral economics literature that highlights how people make poor consumption decisions because they have cognitive biases that lead them to overconsume products that are harmful, even though they would rather prefer not to, taking a long run perspective, but the short run perspective sort of overwhelm their long run perspective. Like there is one very interesting study in the US that suggests that the internalities for cigarette smoking are 100 times larger than the externalities. They're like $35 a pack of cigarettes. So this is a very important argument if we are seriously interested in imposing health taxes. Next slide, please. I mean, all taxes have problems, but I think probably health taxes have more advantages than most taxes. We know that they reduce the consumption of harmful products. We know that reduced consumption in most cases improves health. Improved health, we know, lowers medical costs. And at the same time, in a very large number of situations, these health taxes will raise revenues relative to the counterfactual of low or no health taxes. But like other products, there are bound to be drawbacks, which we should be aware of. And I think the first one that is a valid concern is that if we raise the tax on one product, we may induce people to substitute another product that is, say, equally harmful. For example, if we tax sugary beverages, but people substitute biscuits and cakes, we're not going to achieve the desired health and other economic impacts. That's the first of the drawbacks. Abdul mentioned, I think, regressivity. It's a concern, but at the same time, there is a lot of evidence that low-income consumers actually their response to health taxes is much stronger. So they reap a very large share of the health benefits because their reduction in consumption is higher. But it is something that we should bear in mind, and I'd be interested to hear panelists' views on that. Of course, if you have a high tax on a low volume product, there is a risk of illicit trade. But as with all goods, whether they're health taxes or other high value taxes, enforcement is key. So you can't separate health taxes from having a robust enforcement mechanism. And then finally, this is coming back to the internalities argument, there is a view that, well, these taxes are just paternalistic. And I think it's not necessarily because they disagree with taxing, say, tobacco. It's more that they fear that a huge range of taxes could be introduced to modify people's behavior in one way or another. So, and I think that leads us to the question, well, you know, how serious of an issue is this in developing Asia? Should we really be concerned about it? Does it come to the top of the list of products that we should be trying to disincentivize consumption with taxes as well as other regulations? So next slide, please. I don't know if you can see this chart, but basically it's trying to estimate the cost of death and disability in all of the countries of developing Asia from alcohol, tobacco, and sugar-sweetened beverage consumption, which we have very rich medical data that we can estimate these costs. And basically, I won't go through the methodology. The methodology is in the paper. It's cost of illness approach. It's well known. But basically, every year, on average, there's about 2% of GDP is lost in terms of lost productivity from death and disability from consumption of these products. And most of that is falling on males who consume much larger quantities of tobacco and alcohol than females. This isn't, of course, the total cost. We're totally ignoring here the direct costs, mainly medical costs data that's on top of the lost productivity from premature death and disability. And this would probably add yet another, 50% or more on the costs. So I mention this because I think it's a good metric of saying, well, are the corrective taxes that we're collecting of the same order of magnitude or less or much higher than the costs that are being incurred from consumption? So let's go to the next slide, please. And I'm going to go now. So now we're coming to the state of play. And I wanted to do tobacco first because developing Asia is the world's major consumer of tobacco, with China alone accounting for 40% of global consumption. And Vietnam and Indonesia are also major producers and consumers. So this chart shows taxes as a share of the product price. All of the lines except the very top one, which are advanced economies, are the sub-regions of developing Asia. We've seen some modest improvement over the past decade or so, but it's leveled out actually during the pandemic period. WHO recommends that tobacco taxes are at least, excise taxes are at least 70% of the retail price. And as you can see, most of the regions, in fact, all of the regions of developing Asia are significantly lower than that. This is not the only metric, and I'd like to actually shift to a different metric. This though does suggest that there's plenty of room for further increases in taxes relative to both advanced economies practice and WHO recommendations. But tax collections are also an important metric. Next slide, please. Now, I did have a chart that showed tax collections against the cost of death and disability, but I decided it would take too long to explain and had too many data points and too many things to actually make it worth doing in a 10-minute presentation. But the basic point is that the corrective taxes are far, far lower than the attributable productivity losses that we are seeing. And of the 30 countries for which we have data in developing Asia, 22 of them raise less than half the tobacco attributable productivity losses from tobacco taxation. And in 15 of these, that's half of these countries for which we have data, tobacco tax revenues are less than a quarter of the productivity loss. And that's before we add in medical costs and other things. So the particularly large shortfalls, they're in Central Asia, in Pakistan, Vietnam, Myanmar, India, and some of the Pacific Islands. Now, it's not just because taxes are low. In fact, some of them, they perform quite well on this tax as a share of the pack price, but the yields are reduced by poor tax design, with complicated systems, with tiered rates, ad valorem taxes that are levied on the factory gate price rather than the retail price, and other problems relating to lack of indexation of specific taxes. So a lot of nitty-gritty design issues that actually mean that the tax system isn't really delivering in the way that it was hoped in the first place. Next slide. Let me now turn to alcohol. So actually alcohol consumption is low, relatively low in developing Asia, except in East and Central Asia. And of course, we know that not all alcohol consumption is harmful. So therefore, it's, the policy implication is we should focus health taxes on the health harming characteristics, that is to say, the volume of pure alcohol that's being consumed. I have to say that if you go into this, alcohol taxes are complex, they're often different for beer, wine, and spirits, and they may well be low yielding, reflecting various long-held national preferences. And I guess just as in the case of tobacco, this suggests that there is plenty of scope for improvement in tax design and structure in many countries. I come from the UK, and they recently did a reform of a tax system that dates back to the 18th century. Maybe that's an extreme case, but I'm sure that there is plenty of room in many other countries in developing Asia. Let me just give you next slide, please. One chart. This is the, this shows for countries which we have data, it shows the cost of alcohol attributable death and disease on the vertical axis and the corrective alcohol taxes on the horizontal axis. So anything above the 45-degree line has higher costs than corrective alcohol taxes. And that's particularly the case in Mongolia and Kazakhstan, in Korea, even in Pakistan, actually, which collects obviously very little in alcohol taxes because it's very significantly curtailed legally. So I just think this is a good example, and we could show the same for tobacco if we had, I have the same chart for tobacco where almost every country is above the 45-degree line. So basically, corrective taxes are pretty low relative to the costs of consumption. And then finally, let's go to SSBs, sugar-sweetened beverages. Next slide. WHO recommendation, keep sugar consumption below 50 grams a day to help control obesity, diabetes, secondary diseases like diabetes and heart disease. And just one can of Coke will give you nearly 80% of the recommended daily consumption. We've seen in other areas that taxes on sodas can significantly change consumer behavior. For example, Saudi Arabia has a 50% tax, and it's seen a 33% decline in soda consumption. That said, the research on the link between the reduction in soda consumption and the impact on health, which is longer term, is still ongoing. And I think it's not as clear cut as the case would be in alcohol and tobacco. But that's not to say that diabetes and heart disease and obesity are not significant problems. And particularly if we look across developing Asia and the Pacific Islands, some of the Caucasus, China, Taipei, Sri Lanka, and Thailand all have quite significant levels of diabetes and heart disease that are related to high sugar consumption. So next slide, please. I think I'm probably running out of time. You may need to prompt me if I'm overrunning. 14 countries in developing Asia have an SSB tax. And most of them are Pacific Island states. And I look forward to hearing our panelists from the Cook Islands, as well as India, Philippines, and Thailand. There's a lot of variation in how SSB taxes are done. And again, as with the case in tobacco and alcohol, there's ample scope to improve tax structure and design. I think we have some very good examples in Thailand, for example, SSB taxes encourage producers to reduce sugar content. But in some other countries that have used, for example, import duties rather than excises, what it's done is encouraged the substitution of domestic SSBs for imported ones. Next slide, please. In the paper, I have some case studies which are used to highlight some of the sort of recommended policy approaches. I don't really have time to go through them, but we look at tobacco tax, we look at how you embed health taxes in a broader tax reform, and we also discuss the experience of earmarking corrective taxes, which again Abdul mentioned in the opening. So let me wrap up on my last slide. Next slide, please. Three main conclusions, policy priorities. I think the first, which is covered by the first two bullets, there's a lot of potential for higher tobacco and alcohol taxes in developing Asia, given the productivity losses that we are seeing from death and disability. And SSB taxes are perhaps a first fiscal step towards a better diet. And they could, in the current context, as countries exit the pandemic, provide additional revenue while improving outcomes, health outcomes, and cutting costs. But as I said, for all three taxes, there's a lot of scope to improve corrective tax design and effectiveness. I've mentioned some of the more detailed approaches. I don't think I have time really to repeat them now. And then finally, there are a number of quite effective strategies that come out of the case studies for introducing corrective taxes, including linking up health and finance objectives, anticipating how producers and consumers will respond to a particular tax or tax change, not forgetting tax enforcement. And I think perhaps lastly and importantly is to consider expenditure policy and product regulation alongside tax policy objectives. This is not the only control instrument that is available. There are many others, and they should be sort of seen as a part of a package. So with that, final slide. Thank you. Let me pass to, I think we have our moderator is Grace Chan from the ADB. Thank you.
Thank you, Grace, for your excellent presentation. Good morning, good afternoon, good evening, everyone. I'm Grace. I'm a senior economist at the Asian Development Bank. Today, after the presentation, we will have a panel of experts to further discuss the health issues, such as health tax issues, such as the tax design, demand responses, distributional consequences, the use of corrective tax revenues, and then the role of ADB in supporting effective implementation of health taxes. Today, our panelists are Mr. Arun Dutta, Senior Health Specialist at ADB. Good morning, Arun. Mr. Jeremy S. Paul, Head of Fiscal Policies of Health Unit, Health Promotion Department, WHO. Good morning, Jeremy S. Ms. Hannah Rose, Principal Research Officer, Research Unit on the Economics of Accessible Products, University of Cape Town. Hi, good morning, Hannah.
Good morning.
Our last panelist is Mr. Xavier Mitchell, Director, Revenue Management Division, Cook Islands Ministry of Finance and Economic Management. Mr. Mitchell has the Cook Islands Customer Service. This agency has implemented health tax, which was introduced in 2013. Over the past several years, he has been involved in reconsidering current health tax and proposes to implement changes going forward. After today's panel discussion, we will also have some time for the audience to raise questions. At that time, please post your questions in the box. We will try to answer as much questions as we can during the seminar. Okay, let me start with our discussion. So in Chris' presentation on mobilizing health tax in developing Asia, he mentioned that as the post-pandemic recovery gathers momentum, there are scope to doing more on health tax in developing Asia, such as improving corrective tax design and effectiveness. I would like to hear the views of our panelists on this point. Okay, let me go one by one. Maybe I start with Arun. So Arun, please.
Thanks, Grace. Of course, I think Chris's paper is very timely. I'll come back to this maybe later in the panel, but I just want to acknowledge that we do have in this late stage of the pandemic a call to really address a lot of the gaps that were identified. So I think new sources for financing resource mobilization are being actively discussed. Some of this will be international money, but I think domestic resources can be raised from these health taxes are also being discussed. So this paper, I think, will be very welcome in a lot of policy circles. Thanks.
Thanks, Irene. Maybe let's hear from Jeremiah. Yes, Mr. Paul. You're on mute. Please unmute.
So I agree with Chris' findings and recommendations. If I were to summarize it, for example, that health taxes is SMART, and SMART is an acronym wherein it saves lives, mobilizes resources, addresses health inequities, reduces future health systems burdens, and targets NCD risk factors or non-communicable diseases, which is just a summary of some of the points that Chris mentioned in his presentation. And number two, I really believe that post-COVID, a lot of countries will really face revenue pressures, fiscal challenges. And at the same time, they need to make sure that inclusive development will proceed. So how do you do that? And one effective way to doing that is really to implement health taxes, because you need every revenue, and also you need to make sure that you prevent diseases in the first place, chronic diseases. And the third point that I'd like to stress is that WHO, my team works on these health taxes, but WHO is willing to, is open and is working will work closely with you on this area of health taxes, because we have a team specifically on health taxes.
Thanks, Jeremiah. How about your view, Hannah? Yeah, Ms. Ruth, please.
Yes, thank you. I absolutely agree with Chris' presentations. There's a lot of scope for doing more on health taxes. On the policy side, Chris stresses the importance of both tax rates and tax structures. And I couldn't agree more, because the high rates cannot accomplish much without the proper tax structure. The paper also talks about the importance of tax administration, because without the effective tax administration, policies alone cannot achieve the intended goals. And so the best recipe, in my opinion, for success is high tax rates with proper tax structures combined with effective tax administration. And the paper also lists numerous resources available to countries to support the implementation of corrective tax reforms. And one of the recent resources that wasn't listed because it's new, it's a health tax work stream embedded in the World Bank's Global Tax Program. And it focuses on supporting countries to formulate and implement policies for health taxes, and provides technical assistance on both tax policy and tax administration. And another important source for technical assistance is a CTC knowledge hub at the University of Cape Town that focuses on enhancing capacity in tobacco tax administration. Thank you.
Thanks, Hannah. How about your view, Xavier? Sorry.
Thank you. Thank you for that, Grace. I just wanted to give a bit of a perspective and background from the Cook Islands and the Pacific. So in terms of the Cook Islands, a review of our health taxes was completed in 2018. A lot of what's reflected in the comments that Chris has made came out in that. The review highlighted that there is scope for improving our corrective tax design and its effectiveness in the Cook Islands. And it's likely that that will be the case across the Pacific as well. I guess another important factor to mention is that, you know, like other jurisdictions, and especially Pacific nations, the COVID-19 pandemic has had a significant impact on our economy. With GDP contracting by over 1/4, despite large stimulus programs, the Cook Islands economy is estimated to be one of the most severely impacted economies in the Pacific region, and also one of those most severely impacted around the world also. The Cook Islands Ministry of Finance and Economic Management has estimated that, like other Pacific nations, it will take a number of years before our economy fully recovers. So as you all know, that ensuring the design of our health taxes are effective is one way that we can both increase tax revenues and arguably improve the health of our people. In terms of our health taxes, they were first implemented in 2008, with subsequent changes being implemented in 2013. A further review was undertaken in 2018, so more recently. And that review highlighted that there was definitely areas where we could improve the corrective tax design and its effectiveness in the Cook Islands and potentially across the Pacific. Thank you.
Thanks, Javier. Okay, thanks for sharing your views on the outlook of this house tax implementation in the post-pandemic world. In today's Asian Development Outlook, actually there is a case study on corrective house tax practice in the Philippines, which is viewed as a successful house tax story. Jeremiah, given your experience of working in the Philippines Ministry of Finance on house tax, what factors contributed to this success? Are you hopefully they could be replicated elsewhere in developing Asia? What's your view? You are on mute.
Sorry. Definitely, I think this can be replicated in other countries, not only in developing Asia, but other parts of the world. Why do I think so? Because if you do your homework, well, which is one key success factor, in the case of the Philippines, we essentially looked at the experiences of other countries, what are the best practices. We reform the Philippine structure from a multi-tiered structure to a uniform specific structure over a period of 5 years. We raised taxes significantly, and also the Philippines also, when I say we, I was at that time, I was in the Philippine government. So, and also the specific tax rates were automatically indexed to inflation. So doing our homework, we did a lot of revenue estimation. We also anticipated the industry tactics, what I call the scare tactics of the industry, wherein if you increase taxes, tobacco taxes, for example, smuggling will increase, that there will be core challenges. It's anti-poor or aggressive, that if you increase tobacco taxes, revenues will go down. And employment, there will be a negative employment impact. If we did listen to what the industry was saying, we would not have achieved the success that the Philippines has achieved. So there was really courage on the part of the Philippine government. So doing our homework also involved consulting WHO, the World Bank, and the IMF on these issues. The second part is really how you need to be strategic. You need to know the strategies. You need to choose your battles. For example, at the time we were going to raise tobacco and alcohol taxes, and we chose that there will be more significant increases in tobacco, because at that time the Philippines had really one of the cheapest cigarettes in the world, and there were high prevalence, tobacco use prevalence rates. And the other thing is that you need to act political. Doing your homework, the technical stuff is a necessary condition for reform, but it's not sufficient. You need to act political, get political buy-in at the highest levels. In our case, then President Aquino was very supportive, and even in this administration, President Duterte has continued this support for health taxes. In fact, it was during this Duterte administration that it expanded to include SSP taxes and electronic cigarettes, and further increases in alcohol taxes. And you need to build a coalition of reform, because to counter the powerful industry interests and the issues that are raised, what industry was able to galvanize the farmers, the government and the champions were able to galvanize the health sector, the army of white doctors, of the youth, and all of the, it was really a broad-based coalition of champions. So it is really important that the political economy of reform is considered, and framing is important, because what's in it for you? I mean, for the population. This was really this reform, in sin tax reform of 2012, was really framed as a health measures rather than as a revenue measure. Because if it were framed as a revenue measure, the Philippines would not have been able to significantly raise the taxes and simplify the structure to essentially improve affordability. And the results will speak for themselves. There has been a reduction in tobacco use prevalence. There's been increase in revenues from 0.5% of GDP in about 2012 to about 1.2% now, which includes tobacco, alcohol, and SSPs. So also increase in the budget of the health department, and also free health, subsidized health insurance for the poor. So this is really important. So again, if I were to repeat, this is something that can be done. We've learned from the experience of other countries like South Africa, like Thailand. If these countries can do it, the Philippines can do it, so can other countries. It's really requires courage to stand and overcome the scare tactics of the industry.
Thanks for sharing views, Jeremiah. And then let's turn to general view on Southeast Asia. Hannah, your work for Southeast Asia Tobacco Control Alliance has highlighted the significance of gap for tobacco taxation in Southeast Asia. Does the recovery from the pandemic offer some opportunity for countries to move more aggressively on tobacco taxation in this region?
Yes, thank you. Certainly does. And this project with SETCA was really interesting because most of the tax modeling studies are looking into the future, looking at, if we increase tax, what will happen to revenue, what will happen to consumption of cigarettes. But this study was different. Instead of looking forward, we were looking backwards. So we were trying to calculate how much money is left on the table by the governments that do not follow the best practice or some advice that they receive from health tax experts. So we calculated these amounts for Cambodia, Indonesia, Myanmar, and Vietnam. And these figures were absolutely astounding. We found that about 1.3 million premature deaths could have been prevented, and additional $4.8 billion in tax revenues would have been collected in these 4 countries in 2 years prior to the pandemic, if they were following the evidence-based advice or changes that were proposed to their tobacco tax policies. I always say, and we do see it in the data, that if the government does not take the money from cigarette market, the industry does. What it means that if a government does not follow through on the health tax reforms, the industry usually increases prices on its own. And what this pandemic did is to increase the cost of consuming tobacco, alcohol, and SSB because of the comorbidities with COVID. So now it is even more important to curb the use of these products because their presence is a serious threat to the recovery. When it comes to health taxes, we know what to do, and JP just said that, we know what to do, but countries just need to find a political will to follow through. Thank you.
Yeah, thanks for sharing it. This is really very insightful for Southeast Asia and then actually in general developing Asia. Yeah, thanks, thanks, Hannah. Pacific Islands have been leaders in the taxation of unhealthy foods and beverage. Xavier, your work focuses on Cook Islands. Looking back on the past few years, how do you assess the progress in this area? How has concerns over the potential adverse distributional impact been addressed in Cook Islands? Thanks.
Thank you, Grace. So as mentioned earlier, in terms of progress, the most recent change to health taxes in the Cook Islands occurred in 2013. At that time, a decision was made to implement health taxes via the imposition of excise tax on relevant goods. Those goods include sugar-sweetened beverages, alcohol, and tobacco. So as a part of that reform, the government endorsed imposing an increasing excise tax on these items progressively over 5% annually. In 2018, after the 5-year period, another proposal was put forward to government to continue with the 5% incremental increases in excise tax. However, at that time, the work sort of paused and Cabinet requested that evidence be provided to show benefits that the continuing increase of excise tax would have for the Cook Islands. It was also actually put on hold due to other priorities relating to COVID-19 and only recently revisited. So later in 2018, another review was undertaken in the Cook Islands and in particular on health taxes. It identified a need for further progression and development of Cook Islands health taxes. The review identified opportunities to broaden our health taxes to include the imposition of excise tax on additional sugar-sweetened beverages and potentially food. Over the years, Cook Islands has been a leader in the Pacific in terms of progressing health tax design and implementation. However, it's clear that further progression is required to further develop and amend our health taxes to achieve the outcomes that are sought by our government. In saying this, our government does recognise the importance of continuously reviewing health taxes and the rates we use. We believe this approach will lead to the achievement of the country's health targets, generate additional revenue, and also aligns with our government's national NCD strategy. In terms of distributional impacts, information is available to determine the elasticity of demand and how health tax is expected to affect bio-related decisions for different segments of our people. However, additional work is needed to assess the potential adverse distributional impacts of our health taxes. Thank you.
Thanks, Xavier. Irene, your work at the ADB monitors health issues across developing Asia. Given the importance of corrective health tax interventions to support better population health, reduce medical costs, and supporting revenue mobilization, what role do you see that the ADB can play to support implementation of in developing Asia going forward? Thanks.
Thanks, Grace. Yeah, I'm happy to respond on that. So just to give context on ADB's role, as I was, I think, mentioning earlier, we currently have a global call for expanding spending on health. This includes pandemic preparedness and response, for which global partners have identified an annual financing gap of $10.5 billion from international sources for the next 5 years. We also need to resume the progress on essential service coverage towards UHC and increasing spending on non-communicable diseases, as I think the speaker from Cook Islands just mentioned. There's not enough resources going towards that. So across all of these areas for which resource mobilization is needed, there are also additional new areas that have perhaps taken a back seat, like climate change, addressing the learning losses, and probably from this year, food insecurity. So health is competing in the social sector and beyond. And to get back to ADB, we are engaged in these discussions as a policy actor and important financier. We are in the G20 Joint Finance and Health Task Force, where there's a lot of discussion around new resources for health, and also in regional fora like the ASEAN Center for Public Health Emergencies, which is coming up. So there is the hint that net new resources will need to be tapped, and net new is hard to do. So here, specifically, first, ADB is working on a lot of health sector reform policies, and we're providing grants and lending. And each of these policy processes are contending with the headwinds of fiscal consolidation that I think have been mentioned in the ADB report. And in this context, what net new can come up is going to be a hard internal discussion between a lot of our member countries, and ADB is well positioned to, I think, support discussions around taxation. And new or expanded taxes on public health bads, as Chris's paper discusses, are very much in play. In fact, in places like India, where I am right now, alcohol excise taxes have been much in the news. This is really coming up as a major revenue spinner for the local government, and it's helping to cope with resurgent public expenditure, especially in the post-pandemic phase. The second, ADB is a significant provider of technical assistance for health system strengthening. So through the background note, which we provided, which complements Chris's paper, we discuss how scaling up or introducing taxes on public health bads is a complex decision. We heard from Mr. Paul and the Philippines' experience of the political economy of these taxes. So ADB is a recognized provider of resources to do the homework that he mentions, each step of the decision-making process, contending with the political economy and being a neutral convener for the policy give and take. So that's an important role that we play and can play. And finally, ADB has the multi-sectoral expertise and the links with the actors in Ministry of Finance, Ministry of Industry, and Ministry of Health, which can help on good engagement. I think a lot of the panelists have brought up. We need that engagement for the taxes to be properly designed and successful in terms of prioritization and allocation, including the pro-poor allocation that helps to ameliorate some of the distributional issues wherever identified. So we look forward to that role, and this may well be our biggest contribution, in fact, to bring together different sectors in the decision making. Thanks. Back to you, Grace.
Thanks, Irene. Actually, during the ADO dissemination, we received a lot of discussions on whether health tax are regressive or progressive. We would like to hear the views from your experience on it. So maybe I'll just seek views from Jeremiah and then Javier. Could you please share your view? Thanks.
Yeah, yes. First of all, the issue of regressivity should be seen as from an overall tax designs. It's not only specific, it has to be viewed from a revenue and expenditure side. So whether a tax system is regressive or not on specific. The other one is that the issue of regressivity at least from the Philippines was something that we had to grapple with, but we essentially argue that the incremental revenues, additional revenues generated for this will essentially be used to provide free health insurance to the poor. So in fact, since the poor are very price sensitive, they're the ones that disproportionately benefit from the health impact. So if the issue of regressivity, bottom line should be seen from a broad perspective. In recent research, for example, by the World Bank, the extended cost analysis shows that if you view it from a general broader perspective, health taxes are actually pro-poor or progressive. So that is my take on it, and also based on my experience in the Philippines.
Thanks, Jeremiah. Javier, please.
Yeah, thank you, Grace. I would agree with those comments. So in terms of the Cook Islands, like across the Pacific, our minimum wage is rather low. So for that reason, health taxes would at first appear to be regressive. So as you all know, regressive tax is one that takes a larger percentage of income from our low income earners than from high income earners. and affect people with lower incomes more severely than those with high incomes. Given the low wage rates in the Cook Islands, our health taxes appear to be regressive. As we all know, consumption taxes are generally a regressive form of taxation for raising tax revenue, since lower income individuals spend relatively higher proportions of their income, the consumption, and allocate a relatively small portion to savings. However, from a public health point of view, such taxes can be viewed as progressive. In my view, our health taxes are progressive measures because they ultimately benefit low-income earners relatively more once health costs and the health burden is taken into account. Thank you, Grace.
Thanks, Javier. Indonesia is a major producer and consumer of tobacco products. Hannah, based on your work, how could tobacco taxes could be more effective in curbing and deferring consumption? And then, do you think Indonesia can emulate the successful experience from the Philippines in rising tobacco and other health taxes? Thanks.
Thank you, Chris. This is a good question. Indonesia is one of those countries where when you look at the tax policy, you think we're on the right path because they have specific tax structure, which is the recommended tax structure. They have regular tax increases. So one would say what to do more, but the problem with Indonesia is that their tax structure, because they tax different cigarettes with different rates. They have what we call tax tiers, and where in these tax tiers, cigarettes that are of different type or produced in a different size of a facility are taxed differently. But all cigarettes, in fact, independent of their types or size, are causing the same harm. So this is economists see this as a violation of the externality rule, meaning, if the taxes are there to cover for externalities, all cigarettes should be taxed at the same rate. So these differential taxes promote substitution towards cheaper tax tiers, to lower tax tiers. And so a lot of people in Indonesia, when there is a tax increase, instead of quitting, they just switch to a different cigarette type. So in this way, they can legally avoid tax increase and just by switching the brand. And this is why this impact of the tax policy in Indonesia is not as effective as it should be, because this allows smokers to basically escape these regular tax increases by just switching to different cigarette type or different brand. So in the Philippines, they also have a similar system, and they had different tiers, so different cigarette types that tax differently, and they managed to get rid of it. So that was the biggest, accomplishment in the Philippines was, this simplifying the tax structure from multiple tiers to just single tax tiers, single tier. So Indonesia needs to do the same thing. It needs to find a political will to simplify their tax structure. They already began the process of doing that. They, I think initially we had about 19 different tiers, and now we're down to about 8. So the progress is there, but it's very, very slow. And also we need to pay attention to their lowest tax tiers, because the lowest tax tiers are the back door. They allow smokers still continue to smoke and not spend a lot of money on cigarettes. So so these lower tax tiers are becoming quite affordable. Indonesia needs to find the political will to change the system. They should do it fast, because otherwise they will not make progress towards a healthier society. Thank you, Chris.
Thank you, Hannah. I think we are already running out of time, so let's turn to some questions from the floor. Maybe we only have time for one question. Let's see. The first question from the floor is directed to Chris. Okay. The question is how much of the consumption of harmful products is because of cognitive biases, as Chris says, and how much is due to psychological addiction? The policy implications differ. So if it is mainly cognitive bias, can nudges work? If it's mainly psychological addiction, maybe tax will not change the behavior much if not accompanied by treatment and the supporting programs. Chris, any comments?
That's a very good question. I was going to talk about addiction, but I actually see the problem of addiction is one of imperfect information, mainly that people don't actually. There are a lot of people who do not realize the risk or the risk of addiction. So that there's a missing. There's an information imperfection there, and taxes won't necessarily address that. Whereas, clearer product information, especially to youth, would help. But I think the other element, which perhaps we haven't discussed, is the difference between the impact of taxes in getting people to reduce consumption vis-a-vis stopping them starting in the first place, especially for tobacco. So most people start using tobacco in teenage years, and it's very clear that high prices are very effective in deterring starting consumption. So I don't think that's a full answer to the question, but I do see the cognitive biases as being a more important argument for taxation than for health taxes than addressing psychological addiction, which seems to me mainly an information gap.
Okay, thanks, Chris. 1 minute. There is one question from the floor yet. I see Hannah already addressed the third question. So what is the best way to deal with the impact of higher tax on producers, particularly farmers? Very quickly, 1 minute, Chris, please.
So I read an interesting article just this morning, actually, that says, it's important to compensate producers and give them alternatives, but it's also important not to overestimate the impact on sort of in the scale of it, where these are typically a small proportion of the agricultural workforce. They may be a bit geographically concentrated, but there is a lot of misinformation about the extent to which producers are harmed by taxation, especially if it's an export-oriented economy.
Thanks, Chris. Thank you, everybody on the panel, and thanks, Chris. Thanks, everybody. So I think we have the time we need to close the session now. So I would like to pass over to my colleague Tom to wrap up the seminar today. Yeah, Tom, floor is yours, please.
Thank you very much, Grace. I think we're almost out of time, so I will keep this super brief. I'm Dong-Yeon Park of ADB's research department. So above all, I would like to thank my colleagues from ADB and CGD for organizing what turned out to be an excellent webinar. And special thanks to Yotin Jinjarak, my colleague from ADB, and Chris Lane of CGD in particular. Let me now recite 3 key messages on health taxes from this year's Asian Development Outlook 2022 theme chapter on mobilizing taxes for development. First, corrective health taxes deliver a double dividend. Corrective health taxes raise both fiscal revenue and improve public health. Second, as JP mentioned, political economy factors are very important indeed, but we must not lose sight of tax design and implementation. In particular, design and implementation should keep in mind or should incorporate demand responses, distributional consequences, as well as how to use the collected tax revenues, including through earmarks. And finally, third, health tax revenues can deliver significant additional tax revenues for the region's government. According to estimates from this year's ADO theme chapter, health taxes can raise additional revenues by as much as an additional 0.6% of GDP, while at the same time improving health outcomes and cutting medical costs. I think we all agree today's webinar provided plenty of food for thought on how governments in the region and elsewhere can design and implement health taxes that can improve public health and raise fiscal revenues. So thank you everyone for a great webinar, and have a great day or evening ahead. Thank you. Bye-bye.
Thank you.